Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today my topic of discussion is about a case of suspected retinitis pigmentosa and its associated features of vernal keratoconjunctivitis. This is an 8-year-old child who presented to us in our OPD, and this patient's vision is 22.5 and 20/20 in the left eye. Color visions were decreased, 7/15 and 5/15, and his parents both were first cousins and nobody was having any disease. If we talk about his refraction, he has astigmatism both eyes. This patient has undergone whole exome sequencing by our genetic ophthalmologist, and it was negative for retinitis pigmentosa. This patient has VKC, and he is also being managed for VKC by patanol, olopatadine eye drops, and cyclosporine eye drops with lubricants. And the most important thing which I'm just going to discuss with you is the pigmentary retinal changes over there, which gave us an impression of retinitis pigmentosa. So this patient is also being managed by the medical retina and uveitis team. So let's have a look at his photographs. This is right fundus photograph. If you see here, you can see here bony spicules, and the arterioles were attenuated, although disc was not waxy and pale. This is the right fundus photograph. Fundus autofluorescence. Here you can see that in the macula you will see hyperfluorescence. This is because of the photoreceptors undergoing stress, and because of that they have undergone some damage, and this area is giving us hyperfluorescence, autofluorescence. Left fundus photograph. Here you can better appreciate the pigmentary clumping of the RPEs in the nasal and the temporal as compared to the right photograph. Arteriolar attenuation can be appreciated here also, and the disc is not that much waxy and pale. This is the left autofluorescence. You can see here again the same pattern. In the macular area you can see some hyperfluorescence over there. This is because of the photoreceptors under stress and some damage. This area is giving hyperfluorescence. This is the OCT of this patient on presentation. Here you can see that right and left both they have got macular edema and foveal schisis, both eyes, which is present right and left, and there is intraretinal fluid also. The OCT after the treatment, this child was given oral acetazolamide 125 milligram initially daily, and then on alternate days, keeping an eye on his renal profile. Topical acetazolamide drops were avoided because of his history of VKC, and it showed some improvement. You can see in this left OCT. This is the OCT of the right side. Here you can see the macular edema is settling down after the treatment with acetazolamide orally. It has shown also some good response. Coming towards his anterior segment findings, as I mentioned, VKC, vernal keratoconjunctivitis, all the classical features were there. You can see pannus formation, Trantas dots, all these things, and mild conjunctival congestion is there. Anterior segment photograph from a different angle, it shows how this child is affected. This child has compliance issues also, and we are managing, as I mentioned earlier, with olopatadine eye drops and cyclosporine eye drops, and he has some spikes and flares up of the situation. Sometimes this disease gets controlled, allergic, itching, burning sensation, all these things, irritation, and later on he may also develop sometimes flare-ups. So this is the from anterior segment point of view, his photographs. Talk about the retinitis pigmentosa. It is a class of diseases which involves progressive degeneration of the retina, starting in the mid-periphery and ultimately advancing towards the macula and the fovea. Typical symptoms of this disease are night blindness followed by the decreased visual fields, leading to tunnel vision and eventually legal blindness. Or in many cases, this can lead to the complete blindness. This is showing the pattern of autosomal dominant. Here you can see that it needs only one germ line to be affected. Mutation from one parent is necessary to cause the disease, and it is equally transmitted by men or women. You can see that in this diagram the mother is a carrier and having disease also, and each child has a 50% chance of inheriting the mutation. This is autosomal dominant pattern which has been shown in this slide. This is the other slide showing the autosomal recessive pattern of this disease. Here you can see the two germline mutations, one from each parent to develop the disease, and two unaffected people who each carry one copy of mutated gene have a 25% chance with each pregnancy of having a child affected. This slide shows us the autosomal recessive patterns. This is the X-linked pattern. In this, female carriers pass on the defective X chromosome to half of their sons who are affected by the disease, and half their daughters who are therefore also carriers. So this last slide is showing us the X-linked pattern related to the X chromosomes and how it is contributing and affecting the patients. Retinitis pigmentosa, basically initially the rods are affected and later on the coats also get involved, and it leads to the decreased by apoptosis process basically, and it leads to the outer nuclear layer thickness is affected within the fovea, and it also affects in the lesions and or the retinal pigment deposits in the fundus. So the outer retinal nuclear layer is basically affected. Electrophysiology is very important in these patients, and it shows us decreased A and B waves on the ERG, and visual field is decreased, and we can see the bony spicules and the attenuated blood vessels. Very important point which was mentioned by Dr. Berger in 2010 and published there. You can see here they mentioned that genetics of retinitis pigmentosa is very complicated thing. Genotype and phenotype correlationships are not yet possible. In addition to this multiplicity of mutations, different mutations in the same gene can cause different diseases. And number two, same mutations can exhibit intra or interfamilial phenotypic variability. So this was a very beautiful genetically explained things, that the different mutations in the same gene are happening, which can cause us different disease patterns. And the same mutations, even that one, can also exhibit as intra or interfamilial phenotypic variability. So this process of exome sequencing genetics is a continuous process, and it shows us the exact pathology of the disease, its causative factors, but at the same time we are very much dependent on the electrophysiology. So this case I wanted to discuss with you, as it was mentioned, I earlier mentioned it is being managed by genetic ophthalmologist, medical retina team and anterior segment team, and this child is still undergoing treatment with us. We are managing it, and the only thing which we can do further is about the electrophysiology, because you see this as genetically it was proven that this patient was not having the retinitis pigmentosa. So we need, there are many variants, retinal dystrophies, which can be considered in differential diagnosis. S-cone, extended S-cone is another thing. So we need electrophysiology and further workup to find out the exact cause. But the reason of presenting these things is that these complicated patients with different disease patterns can present, and it needs effective coordinated teamwork to control the disease. I want to thank this one literature review. That one was done by the article Genes and Disease Mechanisms. It was an article beautifully explained all these things by Dr. Ferrari Stefano. And I'm also thankful to the Prof. Hani Mizani, Dr. Abdurrahman Al-Balushi, Medical Retina, Dr. Basmat from the Genetic Ophthalmologist, and Dr. Abdus Salam, Medical Retina. They all helped us in preparation of this presentation. Thank you.